All right. So sorry, I'm introducing myself, right?
Please.
Um, okay, great. So my name is Hannah Wenger. I am a internal medicine trained physician. I work in Indigenous health and medical care for trans populations as well as in sexual health in Indian country. I'm a partner and contractor at the Raven Collective and also an assistant professor of medicine at Penn State University's College of Medicine in Central Pennsylvania. And I'm looking forward to talking with you today about sexual health history taking and clinical decision making. All right. So, we're going to talk today about sexual health in communities across Indian country, especially as relates to sex, gender, and sexuality. We're going to explore sexual health as a clinical concept that's influenced by patient centered considerations and experiences, and share approaches to obtaining inclusive, unbiased sexual health histories and supporting comprehensive sexual health choices for Indigenous patients. Um, just want to share that my opinions, as stated here, are my own unless otherwise specified. The content here is skews clinically and towards adults, so is not really meant to overtly apply to adolescents or youth. And as a settler, I can only speak to certain cultural aspects of this topic in ways that have been taught or shared with me by Indigenous relatives or friends. Just to comment on and appreciate that we're on native land, and I'm coming at you today as we record from Treaty 7 territory in Alberta, Canada. All right. Okay. So, what is sexual health? I will attempt to answer this question with you. So, sexual health is a concept that is framed in several different ways. I think for many of you in the audience who are clinical, it can be framed often in terms of how allopathic medicine looks at sexual health, which is often thinking about um, who people have sex with in terms of their gender or sex, and then whether they're at risk for STD exposures and or pregnancy prevention. There's social and there's also cultural conceptions of sexual health as well. And I would generally say that I think sexual health is often misunderstood or reduced or sort of underappreciated by colonial or Western standards of heterosexuality, marriage, and specific ideas or notions about normative sexual or genital anatomy. So we're going to talk a little bit more about that latter point here by taking some time to talk through what sex is, what gender is, and what sexuality is. These concepts are interwoven but distinct and matter to I think understanding and providing sexual health healthcare services as a clinician. So as you can see here, I sort of am trying to map each thing generally to the sort of identity terminology or language that people often use for things like sex, for example, female, male, or intersex. For gender, things like terms like two-spirit, indigiqueer, woman, man, non-binary, etc. And for sexuality, including two-spirit, indigiqueer, heterosexual, gay, lesbian, and so on. Um, I'm going to start by defining sex with you. So, sex, in a very sort of almost like anthropological sense, is a classification of individuals, of sexually reproducing species based on prototypical body plans and developmental trajectories that are often associated with production of an egg or a sperm or smaller, larger, small gametes. So in humans, this like designation of sex typically is happening at birth by healthcare professionals, usually by visualizing the genital anatomy. And so for female and male individuals who have innate physical sex characteristics that fall within a broad range of what's considered typical or normal based on standard biomedical criteria, they're called endosex or just female or male. And these folks tend to have visually identifiable like vulva at birth or clitoris labia or a penis and scrotum. Um, for intersex traits or variations in sex characteristics, refers to those that differ from normative biomedical criteria for typical female or male anatomy and may be visible at time of birth or present later in life. So I think it's important to also keep in mind that sex is a linguistic term that has two meanings. So it categorizes bodies based on what I was describing earlier, chromosomal sex, by anatomical and gonadal sex, by hormonal sex, and also by legal sex, which doesn't necessarily equate to any of the other like types, sort of like subcategories of sex that I've already described. It's important, though, to acknowledge that societally and socially, legal sex is tied to major rights, things like voting, certain sexual health services, marriage, etc. Sex is also a term that defines practices of physical, mental, cultural, and spiritual engagement involving one's sex body and various conceptions of pleasure or reproduction. So I will probably use these descriptions of sex somewhat interchangeably throughout the presentation, and try to be clear about when I'm using which term, if it's not clear. Okay, gender is an individual's self-conception or personal identity in relation to their sex. It's often, I think, more easily understood as being a deeply ingrained sense of being a girl or a woman, a boy or a man, two-spirit or another gender. And it may include physical, psychological, social, cultural, and spiritual aspects. Sexuality is an individual's self-conception or personal identity in relation to their sex practices or behaviors, their attraction, their experiences of arousal, romance, partnership, reproduction, and or more things. And tends to tie to senses of being heterosexual, gay, lesbian, queer, two-spirit, or another sexuality. And also similarly has physical, psychological, social, cultural, and spiritual aspects. I think it's important to keep in mind that healthcare, like sexual health, is a deeply relational, I think, experience of being, and is important to also be contextualized within that, like within one's broader community and experiences of the community, both culturally and in relation to their traditions around sexuality, sexual behavior, gender, and indigeneity. And I was fortunate to sort of explore this sort of contextualization of sexual health within this manuscript, which I wanted to highlight to you for your reference for later. I also think it's really important to remember that sexual health is a deeply political, ethical, and moral experience, often framed in our society, at least in settler society in the United States, as a concept deeply tied to consent, and what I call consent and well-being. And within that framing of consent, I think there's two main sort of ethical tools there that I want to highlight here, and that is bodily integrity and bodily autonomy. Bodily integrity being sort of a definitional concept tied to the ability to say, yes or no to healthcare intervention on one's body. And it also accounts for sort of individuals or states of experience where one may be temporarily unable to convey their own sort of preferences within those choices, whether it's due to sort of temporary disability or incapacitation or permanent incapacitation. And bodily autonomy is the ability to self-determine, to make those decisions oneself in a cogent and decisional space. And ultimately, I think sexual health itself is and ought to be a very consent-driven process, but acknowledging that socially we make it's often challenging, I think legally and socially, to be able to adequately give consent in some types of sexual health, including reproductive health services in the US in particular. I also just want to highlight that sexual health is something that's on the radar of tribal entities, including tribal political entities like the National Congress of American Indians, with the Dobbs ruling that overturned Roe v. Wade back in 2022. The NCII and several other tribal entities passed resolutions to sort of highlight and convey their perspectives on sexual and reproductive health. And I took snippets of the resolution. It's much longer than this, but the resolution I just want to highlight is support of reproductive rights of American Indian and Alaska Native people, which ultimately I think is inclusive of sexual health services. So NCII conveys their recognition that progress has been made nationwide towards improving comprehensive reproductive health, including access to contraception, family planning, prenatal care, and abortion services, but significant disparities continue to exist for American Indian Alaska Native people who do not have equal access to comprehensive reproductive health services. And then NCII endorses the fundamental right of Native people to access such services, and that they promote the sovereignty of tribal nations to determine access to comprehensive reproductive and sexual health services within their own territories, and that no state law restricting or criminalizing services shall carry the force of law within their jurisdictions, and that they call on state and the federal government to protect the rights of Native people to sexual health and reproductive autonomy. Okay. So I want to talk a bit about sexual health care as a clinical practice. So I think this may be very familiar to you, but just like reflecting back on how sexual health was taught to me in medical school, it was very, very short. It was like, are you sexually active? And then if the patient says yes, you then ask, are you sexually active with men, women, or both? And then based on whether they say men, women, or both, you might, and your sense of what their sex or gender is, you will ask them more questions about things like contraception or STDs. So it's like a very, I would argue, narrow and unclear way of thinking about sexual health. And I would say, a step in the right direction was CDC's publication of something called the 5Ps, which is partners, practices, protection from STIs, history of STIs, and pregnancy intention, which sort of is the framework I'm talking about here, but is slightly like a little bit more than what I was taught in med school. And this was published most recently updated in 2024. But the idea is to sort of help clinicians frame their history taking and then provide sexual health support around STD care and pregnancy. My perspective here is that like this framing thinks about sexual health in relation to assumptions or ideas of sex, gender, and sexuality that are clinically not objective or not objective enough. Like thinking of some examples here of how to apply CDC's 5Ps, like how would you apply this for someone who's 35, is a trans woman who's seeking contraceptive education? In this example, I think your assumption might be that this trans patient has a penis and scrotum, so the contraceptive education they need is different than if they had a vagina and a vulva, and a vulva. And they may have had, surgical intervention. They may not have. It's difficult to understand how to approach a trans patient asking this without appropriate history taking to frame an understanding of their sex anatomy and what kind of contraceptive care would be relevant to their body. Another example is a 60-year-old non-binary patient who's having issues with libido. In this circumstance, you also have no concept based on this patient's gender or sex identity, whatever this phrase term non-binary is being tied to, which usually is around gender, without an understanding of whether they have a penis and a scrotum or a vagina, vulva, and ovaries, because libido issues would be responded to differently based on whether someone's ovary-bodied or testes-bodied. Another example, 25-year-old trans patient who's trying to get pregnant. This may be very confusing for a lot of clinicians if they see a male presenting person asking about pregnancy support around their sexual health. So having a clear understanding, again, of the patient's body parts, the organs they have, is the more clinically objective way of approaching considering pregnancy or pregnancy planning than to, I think, try to understand what's going on because they identify as a trans masculine person. Another 42-year-old lesbian patient who engages in kink and group sex, having more history around their sexual behaviors and sexual experience can help inform clear understanding of how to support their sexual health. But I don't think that the CDC's 5Ps frames conversations around like kink or other types of sort of what I would call sometimes non-normative sex in terms of sexual health care. Finally, a 19-year-old heterosexual patient who is a sex worker. So again, working through the 5Ps, I think it's not going to be common unless the patient's overtly self-disclosing that they are going to be conveying their engagement in sex work, but their disclosure of such may help support their sexual health. Okay, so hopefully these give you an idea of how I feel like the five Ps don't do a good enough job, though they are certainly better than the original way I was taught in med school. Here's how I approach sexual health. So I think through these six major domains, and I have to like admit that the way I think about and talk about sexual health with my patients constantly grows as I learn and understand different nuances of how to think about sexual health, how to think about sex. I will comment here about some changes that I made, including by just going to a conference recently where I went to a really incredible presentation by someone who talked about substance use in the context of sex. So the main domains I ask patients or think through when I'm engaging with patients around sexual health is pleasure and well-being, safety, reproduction, which is a bigger bucket. It's like fertility, pregnancy, family building, and appreciating that goals around family building are not equivalent to pregnancy if someone's pregnancy capable. The other domain being STI care, substance use in the context of sex, and then engagement in sex economies, which is a broad way of trying to think through experiences patients might have around commercial sex or transactional sex. All these domains are not universally relevant to every patient, but are a way that I frame how I take my histories. So again, I hope that I've sort of already prepared this idea for you, but when I think about sexual health, I don't really feel like being guided by any patient level disclosures about their identity, sexually, gender-wise, or in terms of the sexuality, really fully helps me to provide a good sexual health sort of plan with the patient. Instead, I really try to focus my history taking on understanding the patient's sexed body, including their sex organs, most specifically, so that I can provide appropriate, focused clinical care relevant to that aspect of things. So you might be wondering, how do you understand whether someone's sex organs? And you may think, for example, that we already know these things because for patients on every electronic health record or patient chart, there's a legal sex on their chart. But I think it's important to keep in mind that the legal sex of a patient does not necessarily always equate to the sex organs they have. For example, you might have a patient whose legal sex is female who has, ovaries, uterus, was born with ovaries, uterus, vagina, vulva, and then had a hysterectomy at some point for some medical indication. So, they may no longer have their uterus. They may or may not have their ovaries anymore. So that the legal sex marker for that individual would assume that they have a full sort of cadre of the endosex female organs, but that's not always the case. Similarly, so for patients who are trans-identifying, who may or may not identify as a trans woman or just a woman, if you looked at their legal sex and it was an F or female, they would potentially have sex organs that are not consistent with the female legal sex marker in normative ways. They could have, again, penis, prostate, testicles, or they could have had genital surgeries that have resulted in like a neovagina and a vulva, neovulva, and a prostate being their sex organs. So just to say that like the use of a sex organ inventory, I think is helpful across all genders and sexes, and really I think creates a more clinically objective way of approaching sexual health. So here's an example script for how I introduce sex organ inventories. And I want to frame this for you in terms of where I place it in my history taking and then what I say. So, looking to the left here at the boxes, the rainbow colors, I ask the history of present illness. I review a medical history, which would include medical, surgical, medication, family, and social histories. Then I ask a sex organ inventory. And then I ask sexual health history because I feel like I can't know how to provide an appropriate, clinically tailored sexual health history unless I know the patient's sexual anatomy or sex anatomy. And then any appropriate physical exam, and then the assessment and plan. So here's what I say when I get to the sex organ inventory component of my history. I say, I would like to review your sex organs with you. This information helps me to support your whole health, including preventative screenings and specific medical concerns. You can tailor this script to different settings. Some people ask, like, well, I work in the emergency room. How would I ask patients this? I would say, and do you have to ask it to every patient? The answer is no, you don't have to ask it to every patient. But if you think that your decision, your clinical care is going to be like overtly influenced by whether this patient has, ovaries, uterus, vagina versus penis, prostate, testicles, then confirming a sex organ inventory is a reasonable thing to do um, as part of your history taking for that patient. Um, okay, so moving on with sort of the script. In terms of asking about sex organs themselves, I tell patients I want to review a list of organ names using the medical term and ask you to reply yes or no to whether you have the organ. And if you're unsure about the organ names I'm using, just let me know and I'll explain it to you further. And then I often ask after I review the list if they prefer to use different terms to talk about their organs moving forward. This acknowledges that, like, I really think it's helpful to know upfront what language that patients use for their private anatomy, but that if they just told me that they want to talk about their front hole and their back hole, that I still want to make sure I have an understanding of like how that maps to the medical sort of anatomy, like the medical framing and like their actual anatomical components without forcing them, which is not what I'm proposing, and I never do this like requiring an examination of the genital area, which is not necessary. Um, so I review the list of organ names and then I ask the entire list. So I ask them, do you have breast tissue? Do you have ovaries? Do you have fallopian tubes? Do you have a uterus, cervix, vagina? Do you have a vulva, penis, prostate, and testicles? And then they say yes or no. Sometimes people pause and they don't know whether they have a cervix. They don't really know what that is. Sometimes people don't fully know what a prostate is either. So I often just contextualize that for patients relative to what other organs they have, and also try to explain to them what the body part is. Okay. And then I also ask people about whether they have intersex experience. So I sort of also try to screen in for intersex experience by asking if they've ever been told by a health professional that they have intersex genitals or differences in sex development. There's other terms you could use. You could ask, do you have variations in sex characteristics, or do you have a disorder of sexual development? Or do you identify as intersex? I tend to not use the term disorder of sex development, even though it's used commonly in clinical settings. It's not a community-centered or community-driven term. Um, and then I finish off the sex organ inventory component by like asking if they have I often ask if they have any questions about why I asked about the sex organ inventory, and usually patients say no. And then I move on and try to and talk to them about sexual health. So the way I frame talking about sexual health is pretty broad. I tend to say, is there anything you want to tell me or would like to share with me about your sexual health? Importantly, people respond in various ways. Sometimes they say no. Sometimes they say, well, I'm not in a relationship right now, or like, it's interesting. It's often, I would say more often than not, the initial response is usually about their relationship status. So sometimes I take a moment to acknowledge the disclosure and convey that, like, how I think about sexual health, to see if any domains of sexual health that I already reviewed with you sort of pique the patient's interest or needs in terms of what they want to disclose or talk about. Trying to acknowledge too that, like, again, patients have this perspective that sexual health is somehow and for some reason tied to relationship status and or only to STD care or pregnancy, but it's a much broader healthcare consideration than that. So I'm going to go through each domain and just mention to you how I think through these. First, in terms of pleasure and well-being, I often just comment on this category and ask the patient if there's any disclosures that or any concerns or issues that they have, whether it's related to libido, sexual function, and or mental health. I try to create space too for patients to convey goals, not just concerns or issues. And if they bring up questions, like, sometimes I have patients who convey that they have like complexities in relation to their libido and sexual function within sometimes their relationships, and they're looking for support. Sometimes I think clinicians may not know how to help people. I And I think it's okay to gather this information to convey that you might not know the answers, but that you want to work with the patient to identify resources and support. I think in relation to pleasure and well-being, it's also important to consider the role of specialist colleagues in care plans. So if people, for example, are having issues with sexual function involving pain or discomfort, engaging with urologists, gynecologists, pelvic floor therapists, and also, therapists, elders, and traditional healers may be members of the patient's care team that can support their sexual health needs in this way. Safety is another domain that I think is really important. I, again, try to invite patient-driven disclosures if they have concerns or issues, or if they have specific goals or needs. I usually don't myself in my sexual health histories formally screen people for intimate partner violence, but it's something you could do. It tends to come up somewhat organically in these sexual health histories. In my experience, if patients are having challenges in their sexual relationships or experiencing sometimes IPV, but I don't think not every time. I will say I've had some experiences with patients where I'm approaching my sexual health history taking as I'm describing, and then they're disclosing to me for the first time that they've been, for example, like sexually assaulted, because I think the way I'm approaching framing the history is I'm explicitly asking them if they have any issues or concerns around safety. So I've been surprised sometimes by the things that have come up that I wouldn't otherwise have gathered in my sexual health history if I wasn't being this prescriptive, I guess, in the way I'm describing. Thinking about reproduction, fertility, family building, and pregnancy, I think this is another key sexual health component. It certainly, overlaps with, I think, reproductive health, which could be arguably considered separate from sexual health, but I find them to be intertwined. And I think easier for me to think through sexual health history taking by looking at reproduction and reproductive health as sort of a subdomain of sexual health. So again, like similar to the others slides, I invite patient-driven disclosures about concerns or issues, as well as any goals or needs they have. I usually specifically ask, like, if they say they have no goals, I often clarify, do you have any goals around these things in the future as well that we should be planning forward for, including around things like pregnancy and fertility. To make sure that I know if and how to support the patient's goals down the line, including if there's any healthcare things going on that might influence their fertility or pregnancy potential. And again, considering the role of specialist colleagues in your care plan is important here as well. STI care, I hope is slightly self-explanatory, but I often, again, invite patients to convey concerns or issues, any goals or needs around domains of screening, testing, treatment, and prevention. And this is often an opportunity for me to check in with the patients about their and educate them on the availability of HIV PrEP and PEP, as well as DoxyPEP. Okay, this is a new area for me that I'm learning about in my history taking. And again, I mentioned earlier, this was based on a conference I went to and a specific talk I went to where a postdoc shared their dissertation work on interviewing non-binary individuals on their use of substances in the context of sex. And this would be like sexual intercourse, just to frame that term adequately for this conversation. So again, but no different than the pressed slides, I try to invite patient-driven disclosures about concerns or issues. Not sometimes. I tend to also try to directly ask patients if they have any experience with using drugs around sexual activities or experiences, just to be more explicit and not require them to take the onus on to disclose this information themselves. And then I think this is another space where clinicians might not know what to do with the information if they glean it from the patient. So acknowledging that the information received is important to know, and that you might not have all the answers about how to support the patient is I think an important but an okay thing to say in these circumstances. If the patient, for example, conveyed that they have challenges in relation to drug use, specifically around sex. I think in these circumstances, specialists like therapists, addiction or substance use treatment experts, and other allies like elders and traditional healers can be supports in navigating these I think this very complex relationship between substance use and sex. And then the final domain here is engagement in sex economies. And this to me is sort of a broad way, again, of gesturing at commercial sex or transactional sex, where, just to define those terms, they relate to sort of the exchange of sex for things like food, shelter, money. They may be formal professional sort of um, uh, processes for patients like sex workers, or they may be informal, done informally by individuals who are seeking sort of basic resources and needs to get through the day, things like food and shelter. They may also be economies in which sex engagement is not necessarily consent driven, but it may by the individual, but it ought to be important to keep in mind that sex work is something that can and often is like a consent driven process for sex workers to engage in. So, you don't have to go into the nuances of all of these considerations I'm describing when asking about, I think, engagement in sex economies, but just to say that you can ask a patient if they've had any experience or experiences with engaging in sex for food, shelter, or money. And I think that is a reasonable way of asking or screening for patients' support needs around this. And just because someone might say yes doesn't mean that it's problematic or a concern or a thing they want to engage further or talk with you about. I might consider saying, okay, like with the last slide talking about drug use or substance use around sex, if they convey that this is something that's part of their sexual health, asking them if they have any like needs or if there's any support they need from me in relation to that. I think is a reasonable follow-up question, even if you don't have all the answers or all the support resources available. If they said, yes, I need help or there are things I need right now. Okay. So I think, I'm wrapping up here. I just want to highlight that there is some literature and evolving literature out there on sex organ inventories, including their role in even just preventative health screenings like cancer screenings. This publication, for example, talks about it does basically both cis, trans, and intersex patients their sort of perspectives on being asked an organ inventory to be able as a component of cancer screenings by their providers. And they use, a slightly different approach to organ inventories than I'm describing, which is a history-driven one that would be done by the clinician. This is a form that they use. And, this is a way to approach doing sex organ inventories. So you could include it as part of intake forms for a patient's visit in any part of the healthcare system. But they also include the colon, which I think is actually a reasonable inclusion, something to include for an organ inventory, especially because like the anus and rectum may be involved in sexual health. But this is just to say that there's been some literature on this topic area, and the data from this study showed that the use of organ inventories was fairly deemed acceptable by individuals across all genders, including cisgender people. Okay, that's all I got for you today. Just a reminder to be kind. These are my references. And for those of you who are interested in learning a little bit more about gender diversity in particular, if some of the content I shared today piqued your interest or you're wanting to hear more there, these are some specific sort of easy to grasp at and beautifully written pieces on gender diversity, including this pocket guide, which talks about gender diversity by Alok Ved Menon, and beautiful prose and poetry by Billy Ray Belcourt, who is a Two-Spirit First Nations human, who writes about sort of the intersections of indigeneity, sexuality, and gender. All right, that's all I got. Thank you for your time today.
Thank you, Hannah.